Good afternoon, everyone. We're going to go ahead and get started. This is Cami Robinson. I am the Senior Program Coordinator of the Alzheimer's Association Michigan chapters, and I'm happy to welcome you to the 2020 Alzheimer's Association Virtual Research Event. Thank you, everyone who's joining us for this important research presentation. Research drives so much of what we do, and in order to achieve our vision of a world without Alzheimer's disease, we need your help. We are asking everyone on this call to join us in this year's Walk to End Alzheimer's. In light of the coronavirus, this year's walk will surely look different, but we're asking everyone to stand with us and join one of our 25 Michigan walks. You can find a walk near you at alz.org/walk. And if you have any questions, please don't hesitate to reach out to me directly. The walk is the largest event to raise funds and awareness for Alzheimer's care, support, and research. And by joining the walk, you are helping to make a difference. Sign up your walk team today, and you will win a Walk to End Alzheimer's tumbler. So you need to contact me directly at crobinson@alz.org. Don't worry, I'm going to put that in the chat. You don't have to remember it. To join me in the fight to end Alzheimer's and to get your walk tumbler. I'm going to go ahead and pass this over to Cassidy. She is going to be helping to moderate the event today, and she's going to share a few housekeeping items.
Hi, everyone. Thank you, Cami. So I'm Cassidy Cover. I am a program coordinator in the Kalamazoo area. So I'm going to be helping kind of on the back end with some tech issues and things like that. So just a couple instructions on just how to use the blue jeans. So sometimes the controls will disappear if your mouse is off screen. So if you wiggle your mouse on the screen or your finger if you're using a smartphone, those instructions should pop up there for you, and you'll see little icons at the top. One is a camera, and then the one right next to it is a microphone. And so we are making sure that everyone's muted throughout the presentation. So if you could please just make sure that those remain muted, it just prevents feedback and stuff like that from disrupting the presentation. And then when we're all over and you're ready to leave, there's a little phone icon, and you can click that to dismiss the call. And then you also should see some icons on the right-hand side. So there's a little person and a little chat bubble. So that's what we're going to be using. If you have any questions during the presentation, you can push those through. So if you click on chat, you'll actually see an option to put a question out to everyone or a chat out to everyone, or you can do a direct message. So you can see Cami is in there as well. And then you can also direct message me. My name is on the people as Cassidy-ALZ, so you know I'm with the Alzheimer's Association. So if you're having any tech issues or problems, you can direct message me. Otherwise, you can put the questions out to everyone. So again, we just ask that you stay muted during the presentation, and we'll make sure to unmute at the end for question and answers. Thank you.
Thank you, Cassidy. Again, just to reiterate, your microphone will be muted during the presentation. Your camera will be muted as well, so we will not be able to see you. Please leave those buttons alone. That helps Bruno to be able to present without any feedback or interruptions. There will absolutely be time available for questions at the end of the presentation. If you have a question, you can type that directly into the chat, and our moderator, Cassidy, will ask Dr. Giordani at the end of the presentation. If time allows, we may unmute microphones to allow for additional questions. However, the absolute best way to submit a question is to use the chat feature. If you have any additional questions following the presentation, please feel free to contact me again at crobinson@alz.org. I'll put that in the chat box, and I will be happy to connect you with the folks at the Michigan Alzheimer's Disease Center. In a few minutes, you're going to hear from Dr. Giordani, but I just wanted to tell you a little bit about him. Dr. Giordani is a professor of psychiatry, neurology, and psychology at the University of Michigan and adjunct professor of nursing. He is the director of the Mary A. Rackham Institute and the associate director of the Michigan Alzheimer's Disease Center. He's an active researcher and publisher. Dr. Giordani is currently involved in a number of federally and foundation-funded projects involving cognitive and behavioral consequences of medical illness, including cross-cultural studies in Africa and Asia and national and international clinical trials. Over the past several years, he has spoken extensively across Michigan on research in Alzheimer's disease and other dementias. Now, I would like to welcome our keynote speaker, Dr. Bruno Giordani.
Thank you. Hi, everybody. I'm a couple of things. One is I was hoping to do this downstairs where I have a standing desk so I could sort of wander around the way I usually do. But unfortunately, my daughter also had a presentation today on Zoom, and my grandson is downstairs, and he's an adorable 5-year-old, but I wouldn't be able to get a word in edgewise with that. So I think it's better I came upstairs. Also, I'm sorry, like you may have noticed some people when they do these talks and things have a really nifty background on back, but I have a little laptop, so it doesn't have enough memory to put those pretty pictures in the back. So basically you're going to see my my door upstairs in the attic, but that's okay. So so we're going to talk today. Let's look at a couple of things I like to do first. First of all, the university requires a disclosure of financial relationships. Sorry about that. That was the slide. Yep. So I don't have any relevant financial relationships. There's nothing related to this talk, and it wouldn't make any difference anyway because both of my kids own houses in Ann Arbor, or I own houses in Ann Arbor, however you want to look at it. Next slide. So the main thing before we start is I always like to thank the audience. I like to thank you for supporting the Alzheimer's Association. I like to thank you for supporting our center. And most of all, I'd like to thank you for paying your taxes, because part of the tax money goes to fund research in medical areas and in Alzheimer's disease. And so it has an important contribution. And at the end of the talk, we'll talk a little bit more about that, specifically about Michigan. Next slide. So besides thanking you all, I always like to thank the politicians and other people involved in all this, and the people on the ground work, even before we get to the politicians. So thanking our CEO of the Alzheimer's Association, Harry Johns, thanking the idea that through the work of the Alzheimer's Association, we have a much bigger representation of what Alzheimer's means to everyone. I mean, we have the movie Still Alice just as an example, the Glenn Campbell story as another example, and all these other programs, Awareness Month, the Young Professionals organization through the Alzheimer's Association. All of these things now, these are based on the fact that there's so much more awareness of Alzheimer's disease. And I think that's really important, because all of this awareness, next slide, leads to the difference here. The difference is if people are aware, they pressure politicians to be aware. And all of our Michigan politicians have taken really critical stands in either developing more work for Alzheimer's patients directly in terms of getting medications out much faster, or working for caregivers through the HOPE Act. I mean, multiple different things. And I think we have to be especially aware that our state senators and representatives have been really critical and to this effort, and really involved in Washington. Next slide. So I'd like to talk a little bit about today's agenda just briefly. We're going to talk some about the science behind Alzheimer's disease. Not too much, because if any of you have seen any of my other talks or come to other talks in the area, there's usually a lot of that in depth, but I want to really review that because the science of Alzheimer's is still the basis for which all the medications are developed, all of the research is ongoing, and it's pretty basic and in some ways easy to understand. So I want to go over that with everybody. Then I want to talk about the way to talk about the latest research in many ways is to talk to you about the Alzheimer's Association International Conference. So this past year it was in Los Angeles. This year it was going to be in Amsterdam, so it's sort of going to be virtually from Amsterdam. But this conference brings together somewhere around 5,500 or so researchers only in Alzheimer's. This is unlike any other conference for any other disease around. I mean, they're not really for diseases. They're usually for associations, sort of the Association of Neurologists, the Association of Otolaryngologists. But this is a meeting that brings everybody together. I don't care if you're a dentist, an eye surgeon, a neurologist, whatever you are, you can come to this meeting and talk about your area of interest in your work in Alzheimer's. So this has been two things this has been critically important in is that the Alzheimer's Association, by bringing all these folks together, has really advanced research by letting people see all these different areas and talk to these people from different areas about the disease, and also really importantly have brought people from across the world together so that we can better understand the differences in the way Alzheimer's looks internationally and things and those kind of issues. So it's really important. Then I'll talk a little bit about the ways in which our Alzheimer's Center here, our National Alzheimer's Center that's located in Michigan here, really, and actually that's from our logo, involves all three universities and all the research universities in Michigan in one big unit. But talk a little bit about what we're doing. Next slide. So we'll talk about next the science behind Alzheimer's, sort of what's going on. Thanks. So we're going to talk about so in understanding the healthy human brain, you have to understand the brain is really made up of these things called neurons. The neurons are the parts of the brain that sort of make the decisions, that form the basis of the communication, this sort of electric communication that goes on, this chemical communication that goes on across the brain. So there are millions of these large pieces there at the top, the with which is the main body. And each neuron, if you look, I'm sorry, I can't quite point. If you look, each neuron has a long.
Thank you so much.
There's a pointer. So each neuron has a long axon that comes out of it, and this is essentially the messenger from the neuron. And if you move your pointer down a little ways further, you'll see that each of these axons has these dendrites that come off, and then these millions of little connections. Each of those little boxes are synapses, and there's over 100 trillion of those in the brain. So you can see how complicated it is. That little box on the right kind of shows you what a synapse is made of. It's simply a connection between one neuron with the other, but this is done through chemical things. Choline, which is very involved in this process, which is in the brain, is a neurotransmitter, and it helps the synapse and the next neuron talk to each other. So this is I guess my point about all this is, billions of neurons, trillions of synapses. You have to understand this is a really complicated machine up there. That's why little things can go wrong and it can be a problem. So let's talk a little bit about, next slide, a little bit about what is Alzheimer's disease. So the common question usually is there a difference between dementia and Alzheimer's disease? So dementia is, I like this, the Alzheimer's Association was kind enough to give me this slide, but it's a sort of an umbrella. It's the umbrella term. Dementia sort of encompasses any decline, any cause of symptoms that includes memory loss and mental decline. So anything in our lives that is progressive, neurological, and causes this decline. And so within this dementia, Alzheimer's disease, you'll see, is really the most common form. It's sort of in the biggest. That's 60 to 80 cases. 10% of those cases of dementia are also vascular dementia, but you have to understand that vascular dementia and Alzheimer's usually coexist. So that's even, Alzheimer's is involved even in more dementia. And then there are the other very significant dementias that are much smaller, 5% or less, that include frontotemporal dementia, Huntington's disease, Lewy body dementia. All of these areas are areas that, because of the increased research in Alzheimer's disease, we found so much more out about these. The importance of how does frontal dementia that actually appears often earlier than Alzheimer's disease, how does this type of disorder that primarily affects the front of the brain, so it affects behavior much more, how does this disease differ from, say, Lewy body dementia that involves more the back of the brain much more, so that it involves more the visual cortex, visual spatial processing and things, more related to Parkinson's disease. So how do these different diseases evolve, and how does their evolution really affect the symptoms that people have? We're just beginning to understand that. Next slide. So the key to all this is really that older fellow with the glasses up there on the right, Dr. Alzheimer's. Yes, there was a Dr. Alzheimer's. And a little over 100 years ago, now back then doctors were doctors of neuropathology, doctors of neurology, doctors of psychiatry, and so forth. There were doctors of everything, even as short back as 100 years. So Dr. Alzheimer's was doing some of the medical work in a psychiatric hospital, and he met this lady you'll see over there whose name was Auguste Dieter, or Auguste D, as she's been listed in the books. And Auguste Dieter was 51 years old when Dr. Alzheimer's met her, and he was very confused because he wrote about her because she showed a lot of symptoms that were not similar to a psychiatric disorder, but seemed to coalesce together. So there was memory loss, disorientation, language, confusion, hallucinations and delusions. These were not things that he was expecting in a psychiatric condition, so he became really fascinated with her. And then when she passed away at age 55, he looked at her brain. He was also a neuropathologist. He examined her brain as best he could back then, but even as best he could back then, and you'll see the slide on the right, the first thing is the slide he made of a small slice of the brain in pictures it gives us. But even in that simple picture on the far right, you can see what he described, and he described them back then, and everybody has noted them since, the hallmarks of Alzheimer's disease. Things called plaques, which are those dark buildups, and then tangles, which are sort of those longer misshapen pieces kind of coming out in that are visible in that process. So he really talked about how amyloid, sort of clumps of amyloid, seem to be appearing in the brain, and the tangles, and how the brain itself was shrinking. So he was the first person to describe this. Now, Alzheimer's disease had been, it had been around since probably Adam and Eve or whatever. I mean, way back when. But he was the first person really to link it and picture it. So what happened back then is if you found a disease, you got to name it after yourself, and it was named Alzheimer's disease. Next slide. So I want to show you a little bit more closely those kind of critical things that he found. So he found, first of all, these amyloid plaques he talked about, which are these clumps. You can see if the small picture is a picture of what on the left is a picture of what healthy neurons look like with their axons and so forth coming out. But then on the bigger picture, you can see this very misshapen picture, these are amyloid plaques, these brown spots, these roadblocks that get in the way, sort of like if you're trying to drive up 23 right now. It's sort of like there is cones everywhere. There's people getting transferred around. So it's this whole idea of plaques made out of amyloid that are kind of messing, clumping along. And then the other thing he noticed on the right, which is important, is also the idea that these axons, these long messengers that are essentially long tubes that are kind of cemented together by this thing called tau, that the tau somehow in contact of the amyloid was essentially falling away. And so these axons were essentially disintegrating or changing their shape because their cement was falling out. And also we've now found not only that is that these pieces of tau, these cement pieces, these structural pieces that fall out of the axons essentially form what's called tangles, tau tangles. So we get these plaques and tangles. And these tangles we now know essentially can go back up into the cells and really damage the cells, the neurons, and that's why the neurons begin to assume a very odd shape. So really, he pictured this disease 100 years ago, and he was right. He very perfectly described what this disease looked like with very rudimentary techniques. Next slide. So, because of this, we know that Alzheimer's disease, though, is the disease that involves cell death. And it tends to involve cell death in very specific areas. And one of the most specific areas is something called the hippocampus. So that bottom left part, the left brain is a normal brain. You'll see that little line up to the hippocampus, which happens to be the area of the brain that is critical for a number of things, including memory. So it also happens to be important in things like spatial navigation and adapting to movement, for example, which is why many Alzheimer's patients have a lot of difficulty driving because they can't sort of sense where another car is. But its primary role really seems to be the consolidation of memory, locking in memory, and that area begins to shrink. So you see this shrinkage on the right in the hippocampus, so it loses cells. Then the cortex, that shrinkage moves to the outer side of the brain. You'll notice in that other circle, the cortex begins to shrivel up, and in which case, as the sort of brain mass gets smaller, the ventricles, the parts of the brain that are the parts that clean the brain, they essentially just grow larger to take up the space. So it's a very orderly presentation of what happens because we know now that there is pretty much a structure for how that happens. Next slide. So this is what's now called, and again, there are some variants in this model, and everybody has a slightly different model. But this is a sort of amyloid cascade, it's called, the pure model of Alzheimer's disease. And we know this especially, telling me to take my pills, my allergy pills. So we know this especially because we can now image these pieces. Over the past maybe 10 years, we have developed imaging techniques to do this. We can now image amyloid in the brain, which we never could before. So we can look at the distribution of amyloid changes. We can look at the distribution of tau in the brain. So both amyloid plaques and tau tangles we can now see. And then using that bottom picture on the left, we can also look at what happens across the brain as the brain shrinks. So we now have three ways. And these three pictures mark march along with that cascade. So we know when the first thing that happens is the brain gets an increase in what's called brain amyloid. And that amyloid, that unused, which is essentially unused proteins or misfolded, miscooked proteins. Proteins are or precursor proteins are the way the brain gets its energy. But what happens in Alzheimer's disease is those proteins essentially get folded up and wrecked up by little chefs that are supposed to make that good for the neurons to absorb for energy, and they sort of clump together in what's called an amyloid deposition. So that whole first part of this process probably involves amyloid, and that's the picture on the left. It occurs in very specific areas of the brain. And as that amyloid gets deposited, you get inflammation in the brain. So now cells start to dysfunction. There is inflammation. The tangles begin to form. And that's that left picture that shows that even widely you get tau deposits as tangles begin to fall apart. So this is the start of cells falling apart. And finally, at the bottom, you get a loss of neurochemicals, that choline and all those things the cells produce to send messages. Those start to dry up and the cells start to die. They no longer can make choline to send these messages. They begin to die. So you get a loss of neurochemicals, and finally that loss of brain cells, not so much nerve cells, but brain cells, axons and things in the brain. And you can see that missing essentially in that picture on the left. The brain begins to shrivel in. Now, that part about where cells die is important because at this point in time, the only time that we really diagnose Alzheimer's disease is when those cells have died and behavior starts to change, right? I'm sitting here listening. You probably can't hear in the distance, but I'm glad we're not downstairs because apparently the 4.5-year-old kind of lost it. But anyway, I can hear a lot of crying going on. But clearly his grandmother wanted him to come in and stop spraying the yard with water. But anyway, that loss of chemicals and loss of cells, that's when we diagnose Alzheimer's disease. Because if you lose neurotransmitters and what's left of the cells can't connect, and if the axons in the hippocampus, for example, that involves memory, if they begin to die, then we see memory problem. The difficulty with this whole idea is that this bottom sort of thing here, this bottom rung, is 25 years after that those first deposits start to form. So Alzheimer's disease essentially is beginning 25 years before we can actually diagnose it. So this is the key problem with Alzheimer's disease, and this is the key importance of imaging, because we can now image amyloid, like in that top little image there. We can now image amyloid early on in the process, so we can essentially say to some people, look, you have amyloid in the brain and nothing else. That actually, you are at very high risk to develop Alzheimer's. You might not, but you're at very high risk. And then when somebody shows tau in that scan below, on a tau scanner, if they show tau, then we know really we've moved into Alzheimer's disease. And then essentially when the brain shows loss of cells, we know we've got the disease. So that we can now really process out what's going on. So if you look at the next slide, this is another unique thing I kind of wanted to talk about. First, because a lot of people say to me, well, if Dr. Alzheimer's found this disease 100 years ago, like, say, they've done with other diseases, why have we done so little now? And I think this slide shows you why. So the first thing was that August Dieter, described by Dr. Alzheimer's, really, that was in 1906. She was 51 years of age, right? She was actually what we call younger onset Alzheimer's. There's only about 200,000 people in the world with younger onset Alzheimer's. We'll talk about that a little bit later, but this younger onset Alzheimer's disease, these individuals carry very specific genetic linkages compared to everybody else who usually develops Alzheimer's disease later in life. So she was a 51-year-old. And so Kreplin came along and said, and Kreplin wanted to be a bigger shot than was Alzheimer's. And Kreplin sort of said, well, thank you very much, Dr. Alzheimer's. This is presenile dementia. This is essentially people getting old early. So rather than saying this is a disease that affects older individuals, it was sort of like, she's just getting old sooner. So back when I was first doing research in the 70s, when I was like a 5 or 6-year-old working at Mount Sinai in New York, we looked upon this disease as an uncommon disease of people early in life. So you can see that from 1906 into the 1970s and 1980s, people thought of this disease as a very rare disease. But what began to happen is, as we began to look at people, as we began to look at controls who also had memory problems later in life, in the 70s and 80s, we began to realize that early onset was the same sort of basic picture as late onset. So most people develop Alzheimer's disease later in life, in their 60s, late 60s, 70s, 80s, because age is the biggest predictor of Alzheimer's disease. So what we really began to understand is that, but because of that, look, the understanding of biology, the biology of plaques and tangles, that wasn't really sort of resolved till the 80s. We didn't have our first clinical diagnostic criteria. So the Alzheimer's Association and the Academy of Neurology and NIH and everybody got together and said, this is how you diagnose Alzheimer's disease. To diagnose a disease, you need specific clinical criteria. Well, look, that clinical criteria didn't come along till 84. But once that clinical criteria came along, once people could say, okay, I know what this disease is, and I know it occurs in younger individuals, and I know it occurs in older individuals infinitely more commonly, now things started to go. So by the time we hit the mid to late 90s, people were actually doing much more research. Late in the 1900s, 1990s, excuse me, there was the first genes were found. Those linkage genes, presenilid genes to predict early onset Alzheimer's, those were first identified. And other symptoms began to go. We had the first symptomatic drugs in the very early 1900s. Honestly, back in 1985, 86, when I was working at Mount Sinai, we had drugs that appeared to improve memory, except you had to take them every 20 minutes, so it really wasn't an effective way to do it. But those were the very first precursor drugs we were studying that in the late 90s became the symptomatic drugs. These drugs don't affect the disease process, but what they do at the very bottom of that cascade I showed you is that they increase the choline in the brain. They increase the neurotransmitters to try to get a little more memory in there and a little more ability, but they don't do anything about those cells dying. but they do improve communication some. But so there were the first symptomatic drugs, and now everything's sort of crushed at the end. We have new genetic markers being found, the ApoE gene, the sort of risk gene, all these things are being appeared, and then in the 2000s, 2010, 12, 14, we began to do the idea of maybe we could prevent Alzheimer's and show these drugs earlier and things. And then if you look in 2012, for example, in 2012, we had a new clinical criteria. And this clinical criteria said, hey, wait a minute, it's not just normal to Alzheimer's disease. There's this other disorder or this other relationship that appears to grow called mild cognitive impairment, which is a real risk for Alzheimer's. That this kind of, it's not so simple light and dark. It's not throwing a switch. This is a gradual change. So 2012 was so we went from 1984 to 2012 before people better understood the disease. And now in 2016, 2017, we had the even new criteria was suggested. And we'll talk a little bit more about that basically says, aha, if you give somebody an amyloid in a PET scan and an MRI, then we can essentially diagnose risk. That's the A for amyloid. The disease process beginning, which is the T for tau, and with an MRI, the N for neuropathology as the brain begins to die. So this ATN criteria is to say, in a sense, hey, I don't even need to use behavior. I can just model this out with imaging. Now, we know that's not as simple as it sounds, but at least from a research standpoint, that was a first thought. Next slide. So I keep thinking Aaron is going to tell me I have 2 minutes left, but I think I'm doing okay. So this just mentions that idea of that preclinical course. So at the top, we have prodromal or preclinical, before the disease is recognized, amyloid being deposited, things starting to change in the brain. And then as things begin to change more, we now have a criteria for measuring mild cognitive impairment. That means the definition for dementia is these memory problems and these cognitive difficulties affect my daily life. I can no longer function on my own as effectively when I have a dementia. Things are beginning to affect my way of living normally. That's a dementia. But now we know there's this mild cognitive impairment piece here that we see either as heavily laden in memory problems, amnestic, or heavily laden in non-memory problems, so more problems with the front of the brain with decision making, or the back of the brain in vision, or certain parts of the brain in language. But this mild cognitive impairment appears, and really this is the point that over 5 years, once someone is diagnosed with mild cognitive impairment, we now know that over 5 years, about half of those individuals will transition to dementia. But we also know that 10% of them will improve and 40% of them will stay very stable. But at least now we're beginning to understand this course. I've noted before that very early in this research in Alzheimer's disease here at the University of Michigan, we had a patient that we felt was really fit the brand new criteria of mild cognitive impairment. And we talked to her family about this, and they became very, very worried, more worried than they really needed to be. And they immediately got a housekeeper at the house, somebody to stay with her 24 hours and to monitor how she was going. And within about 6 to 7 years, she still had mild impairment, but her housekeeper, who used to bring her to the appointments, clearly was having a lot of difficulty, and her housekeeper developed Alzheimer's disease And this lady remained with mild cognitive impairment, basically taking care of her keeper. So again, it's a very confusing process, but we know overall that people with mild cognitive impairment who fit that kind of clinical picture of there's a change in their memory or their executive functioning or their problem solving or their language skills, there's a change from what happened before. We don't have a specific picture in the brain of a tumor or a stroke or anything like that explaining that. So we know that there's something else going on, and it seems to be, for a good percentage of the people, progressive for dementia. That's why there's a lot of emphasis now, for example, in trying to do research studies and clinical drug trials and other things with people who have mild cognitive impairment, because it seems to be this middle category. Next slide. So let's take a little bit of a picture of what this means in the world. So, and in the United States. Let's center this on the United States. So what's the growth of Alzheimer's like? So right now, Alzheimer's is the 6th leading cause of death in the US. There are 5.8 million people living with Alzheimer's right now, and by 2050, this number will be 14 million. Now, I usually ask a crowd of folks, why do they think this, but we won't bother with the chat room, but think to yourself, oh my gosh, is this spreading dramatically? How can we go from 5.8 to 14 million? So there are a couple of things, and people, usually when we sit in a room, we kind of come up with these things. For one thing, I can tell you, as I mentioned, age is the biggest predictor of Alzheimer's. The older you get, the higher the chance of getting Alzheimer's. So think about the fact that right now, all of you listening and everybody in this conversation, probably half of us will live to be 100 or close to it. So as our age increases, our risk increases. But we live longer, of course, because we're developing more and more medical approaches and things like that to help us live longer. So we're living longer, we're living older, and we have something called baby boomers, which I'm a good example of it. We have this growth spurt in the US that occurred early on, where essentially we have a much bigger population of older individuals in this country. It's infinitely bigger. And so the larger number of people getting older in this country leads to this much higher number of individuals with Alzheimer's disease. And this, of course, is incredibly important because, frankly, with 14 million people with Alzheimer's disease by 2050, if we can't slow this down, sort of based on even how COVID has gone, the wish to sort of slow that curve down, if we can't solve this 14 million people by 2050, the cost to the government will be massive. $1.4 trillion just to take care of this disease. So in terms of worrying about the Medicare or breaking the bank or whatever, this disease will take it. We'll do that. We can't provide for this disease. We can't provide for the number of people. So it's critically important that we come up with ways of slowing the disease. But even if you look at the Michigan figures on the right, there are 4,400 people right now living with Alzheimer's disease in the state. That's up 169% from 2000. Why? People are getting older. Baby boomers are appearing. So this 65% number is really critical. You can see the people getting older from 2019 on and 2025. You can see the number differences in our state, and you can understand why this is such a critical issue. Next slide. So, given this...
About 20 minutes left, Bruno, just so you know. 20 minutes.
Yep. Okay. I have no idea where my slides are in terms of numbers. Oh, yes, I'm way behind as usual. Sorry, folks, talk too much. But we'll move through these fairly quickly because now what I want to do is talk about some of the latest research in Alzheimer's disease. This is what came out in 2019 at the Alzheimer's conference, but I've kind of peppered it with some other things that have come out most critically in the past month or so. So the next slide talks about clinical trials. This is a very significant problem because I usually tell you about all the exciting new amyloid drugs, the sort of amyloid busters that are out there that we can apply to get rid of amyloid in the brain. And frankly, these have not worked out. And so what happened, as you'll see, in 2018, Pfizer spent $1.4 million developing a drug, babenuzumab, that didn't work. And Pfizer basically, unfortunately, said, look, this has almost killed our company. We can't do this again. If we do this, we're simply not going to work on dementia medications or neurology-related medications, neurodegenerative disease-related medications, which was a dramatic hit to this research. I mean, Pfizer here in Ann Arbor used to do all of this work. I used to work with them closely when they were here. And then in 2019, right before the AAIC conference, one about a month before and one just a week or two before, because they were scheduled to do talks and big presentations at that last AAIC conference, Biogen and Eisai, two drug companies together, ended this amyloid-busting drug aducanumab. They had two what are called late phase 3 clinical trials, essentially trials that occur right before it goes to market. So they had done a tremendous amount of research on this drug, and basically they recognized it did not work. And also Roche ended its other trial in mild AD. Both of these studies now were in mild Alzheimer's disease, thinking, okay, if I get people just when that amyloid is beginning to really cause a problem, but Roche discontinued crenuzumab in patients. That was another major blow to research in medications. So there's a whole discussion now is, wow, I wonder if we're looking at the wrong target. I wonder if we're treating people too late in the disease. Maybe even mild Alzheimer's is too late. What can we do? So there's a lot of interest in other drugs. Go next slide, sorry. There's a lot of interest in new drugs and new approaches. Okay, maybe the amyloid didn't work. Let's look for other options in beta amyloid. Let's look for things that disrupt beta amyloid very, very early. So remember I talked to you about the amyloid, the precursor amyloid kind of forms into clumps and things like that. Let's approach that early. Let's strike out those things that create those clumps. Let's not just worry about vaccines for amyloid that break up the plaque. Let's try and work early on. For tau, let's try and approach tau. Let's try and get, say, the immune system of the body to get rid of the tau, because we used to think, oh, we want more tau to kind of keep these cells together, but now we know that tau actually affects the axon. Maybe let's try and get rid of that tau. We know that a lot of this stuff relates to inflammation, so maybe there are ways that we could approach inflammation from the brain at that point. So there's a lot of other interesting things. Now, the other thing is, I would be very excited. I'm still excited, but I would be very excited to tell you about these prevention trials. So these were trials that were started because we can do imaging to tell when people have these amyloid symptoms early. Was let's do research. So the first of these, the most important of these, was the DIAN-2 study, or one of the most important of these, which was fully funded by the Alzheimer's Disease Association. They took a huge amount of their money went into this study, but was to look at this large group of individual families that the Alzheimer's Association had been so important in bringing together, this DIAN-2 cohort. People who seem to carry this genetic link, this presenilin gene, which essentially gave a 50% risk to the disease to a child. And let's take these families and let's look at, say, individuals within these families who don't have Alzheimer's disease, who have amyloid in the brain. Let's give them these drugs to bust the amyloid long before we would predict it might affect them. And yet the Diane-2 studies just in the past month or so came out as negative. Busting that amyloid even early on, which meant that there was no slowing of disease progression, even in the earliest appearance of amyloid. So this was a real this is a single first blow to that system. The A4 study, still results aren't out yet, but the A4 study is looking at what if I take anybody off the street and measure the amyloid in the brain, and if they don't have symptoms of memory but they have amyloid, what if I give them drugs? Or the API study that's looking at a set of genetic risk factors, and also there's another study there that there's another study ongoing too that looks at genetic risk factors. Those studies have not yet come out yet, but then now there are some real concerns again, back to the fact of what to do also with the interesting fact that some of these studies, like the Diane-2 and some of those other two studies that were stopped, seem to suggest that images of the brain look better in terms of amyloid and tau, yet the behavior doesn't change. So what does this mean? Does this mean that they're stuck at that level and that they've sort of been cemented to that level of impairment? But the problem with the Diane-2 study was it suggested, no, this disease continues. So we really don't know what to do right now. We're really spending a lot of time and effort, and there's sort of a renewed effort in the Diane-2 group to look at a lot of different options. Next slide. So there's a lot of also interest in sort of diversifying the portfolio. Let's develop what's called the AMP-AD, which is a whole partnership of Alzheimer's centers and things and research groups together to get drugs faster into research and develop them. Very similar to what we're seeing in COVID. To develop a vaccine for COVID, we've been working on now for Alzheimer's disease. There are lots of new options out now. So there's a new, very exciting result was presented with insulin. People who inhale insulin actually seem to have improved cognition and improved amyloid tau distribution in the brain. Now, just to show you the problems with this, I'll tell you that this study had two components. The first study started with a very poor inhaler system. It was sort of a spray bottle, just wasn't working, and they went to a fancy bottle for another 180 or so people. Those 180 people with the fancy bottle and the perfect spray didn't show any differences, but it was in this group of 49 people with the bad spray bottle that they abandoned. Those are the ones that showed the differences. So you just don't know. But there's another drug, for example, coming out targeting gingivitis, gingivalis. It turns out that the bacteria seen in gum disease also turns up in the brain among plaques and tangles. So there's a lot of interest that maybe these may be markers of inflammation, or they may contribute to it. So there's actually the first drug that comes out that targets this disease process in the mouth. So there's a lot of new ideas coming out because we're looking. Next study. A lot of interest in next slide, a lot of interest in differences between men and women. Do women why do they have the disease more often? Why do we have this differences between men that I've talked about before in terms of presentation? Are there specific sex-related genes? It also appears that women who never sort of got into the workforce and stayed home more, honestly, it appears they have a higher risk. We know that the network of tau distribution in the brain of women is very different than men as the disease starts. So we're beginning to find all these different linkages. We also know that there are cardiovascular disease risks to certain types of mild cognitive impairment, for example, but here we've seen it's only in women. So there's a lot of interest, next slide, in issues with women. There's a gigantic race because of blood biomarkers. So if you remember back on my cascade slide, it showed that there's the idea of imaging. So we do each of these images and we can show people at risk, and we can show people as they continue in the disease, as tau develops. That's a great idea, but that's about $14,000 worth of scanning. You just can't do that for everybody. And it's invasive. You have to lie down, that's not works. And the other way to do this that's much cheaper and much easier to do is to take CSF. So do a CSF study, but nobody wants to get their back poked by a tiny needle. So this idea is out as well. So now there's a huge race to develop these different blood-based biomarkers, and a couple of them look very interesting. So there's a couple from a Japanese firm and things like that. So they're looking at blood-based amyloid tau markers. They're looking at this alpha-synuclein idea, which is this, can we actually see these misfolded proteins in the brain? There was a lot of interest in this thing called NFL, this specific brain protein plasma-based issue, because it turned out that only 2% of normals have an abnormal NFL level, but now as there's been more research, it turns out only 16 to 20% of Alzheimer's patients have it, but 82% of ALS. So we're finding a lot of these markers don't necessarily mean that, but there's a lot of excitement about blood, because essentially every time we go to the doctor, they poke you to look at your cholesterol levels and everything else. Wouldn't it be nice to be able to look at amyloid and tau in the brain? Next slide. There's a lot of increased interest in the LGBTQ community in terms of Alzheimer's. We've become very interested in this in the state as well, because we know that older individuals with dementia from the community tend to live alone. They tend to not to be partnered. They don't tend to have children who take care of them. And so it's a very significant difficulty. And I'll point out to you PRIDE, which is a very exciting research study underway outside of Michigan, but it's a very exciting intervention that targets LGBTQ people and provides the message for that community so that community can use it best. So these targeted messages to different communities, as we're doing different targeted messages to older women in the African American community in Detroit, all these different messages that go out. Next slide. There was also a lot of interest in seizures, because epileptic seizures appear to be much more common in patients with Alzheimer's disease. So there's a lot of interest, maybe some abnormalities in EEG reflect that. Next slide. There's a lot of continued interest I've talked about before about Alzheimer's disease and sleep. There was a lot of interest in let's get rid of sleep medications because they cause an increased risk of falls among individuals, but now some research done suggests that if the meds are working, for some reason, there's a reduced risk in Alzheimer's of problems and an increased risk among white individuals. So now there are some race-related differences we really have to understand. All of these things become much more complex as we study them more. There are some new drugs for this. There's also a lot of interest in specific ways to affect sleep, because frankly, we know that poor sleep quality is definitely associated with deposition of amyloid. Next slide. So these are some better tips for sleep. So we always put the slides on the internet. So I'll just tell you, please, as part of the good for my heart, think about sleep as a critical problem. It's really important. Alzheimer's disease and vision, the next slide, has also been talked about a lot. Last year, I was talking about the fact that that it looked like people who had hearing problems had a noticeably higher risk, even more so than some of the things like gene risks like ApoE. So there was a lot of interest in hearing. So once there's a lot of interest in hearing, the vision people got really interested. But the point is, look, if you have either an uncorrected visual or hearing impairment, that appears to increase your risk of Alzheimer's disease by 20%. But if you have both, your risk is 112%. We don't know whether that is because people withdraw from society. We don't know what's going on. But we also know if you have multiple small sensory difficulties with hearing, smell, taste, even if we look at all these sensory difficulties at the same time, if you have clusters of those, it also increases your risk. So sensory issues may be also important markers we can look at, but they may tell us things about what in the brain is going on. Next slide. Medical care issues. I mentioned this because Deborah Levine, who used to be one of my trainees in internal medicine, Deborah has done some important work looking at this, but right now there's a lot of discussion about the fact that patients with mild cognitive impairment or Alzheimer's disease, because they can't explain themselves, they're going to the emergency room and they are using medical resources much more than necessary. But what Dr. Levine found actually is in a study of patients hospitalized after a heart attack, if you had MCI, you were 35% likely to get coronary revascularization and 35% likely to get catheterization and 45% less likely to get revascularization. These are common things you always do these are gold standard treatments, yet MCI patients were getting them less. So clearly we need to involve physicians in understanding this disease better and look at inherent bias for individuals with mild cognitive impairment as well as Alzheimer's disease. Next slide. There's a lot of interest in approaches to big data. I just briefly mentioned Jenna Weens and Donna who work with us. I work closely with them in looking at big data in the medical record. You know, in one study we've recently found if you just look at the medical record over 10 years, that tells you a lot about who may be developing Alzheimer's disease without really doing Alzheimer's specific studies. So we need to begin to coalesce all the information we have in the medical record. Next slide.
5 minutes, Bruno.
Okay, well, I'm almost going to do it, not quite. Can I get 5 minutes of the discussion? Okay.
Sure.
Or is that close? Okay. Expanding the role of technology. We're interested in technology. What can we do? For example, just the simple thing of putting a phone in a senior residence that leads directly to a physician or a nurse practitioner. We know that reduces hospitalization and significantly improves care. We know that the Alzheimer's disease 24/7 hotline has already shown a significant improvement in care. So these things are really important. Even a little program now has come out to teach kids how to live healthy and reduce their risk for Alzheimer's. Next slide. We've even learned now about a new type of dementia that we didn't even know about, and it's been sort of spearheaded by one of the members of our own Alzheimer's team in looking at something called late. These are individuals who develop dementia in their late 80s and later, and this is a disease that looks like Alzheimer's disease, is a little more frontal-based, a little more executive-based, but it's not related to amyloid tau. It's related to a different protein called TDP-43. So now we've learned, and my mother died in her late 90s of Alzheimer's disease and really didn't develop Alzheimer's disease till her mid to late 80s. This is probably what she had, and because we couldn't understand why medications didn't help. Next slide. So what's really going on now is a whole change in how we do things. We need to find a way to reduce these risks of Alzheimer's disease since the meds, we aren't finding that magic medication yet. So some of the risk factors we've shown and I've talked about in previous research, past head injury, gender, genetic makeup, we can't do much about that. But these other risk factors that we know we've shown now already with research, exercise activities, social emotional behavior, social emotional support, our maintaining our general health, watching our diet, these 4 things we can now approach. Next slide. And so now there's a lot of interest in prevention because we've already done one study, one study's been done that showed that if you even adopt 4 to 5 of these low risk factors like walking more, eating better, and so forth, it reduces the risk by 60%. And that's true at 32% even in people who have a high genetic risk of Alzheimer's. So that even that way you can reduce your risk. But it's very complicated still. We used to say, oh, people who live in high air pollution areas have an increased risk of Alzheimer's disease. But now it gets confusing because if you look at women, those with higher cognitive reserve have a much reduced risk than those who don't have as much education and what we call cognitive reserve, past experience and things. So it's very confusing. But what we're doing are these new studies across the U.S. are 5 pointer sites. These are studies that are doing half of their people with a whole lifestyle intervention in which you interview the person and you find which of those basic things we can change and you start to change them. Or the other half of the group will get a very fixed program that sort of changes all of them without being sort of fixed. And as a matter of fact, on the next slide, it shows you that across the world, these studies are starting. Now, I'll leave to you why the United States won't use the word finger for I'm going to give you the finger or put you in a finger trial. But these trials are starting across the world. And each trial, though, has to include exercise, nutritional counseling, social stimulation and cognitive training, computer-based training or other things like that, and improved self-management of medical conditions. These are the worldwide finger trials, and they're all coordinated, and the data is all coming through the Alzheimer's Association. But the key is they're all being interacted. Before I talk briefly about our center, I'll show you Louise Hame, who died at age 22, purported to be the oldest person. There have been all sorts of discussions, but the important thing about her is she rode her bike till she was, I think, 117 when she fell off and fractured her leg and she couldn't ride her bike anymore. She used to say, you know, you've got to diet and exercise. So even when she was sitting, she was dieting. She had a good breakfast every morning. She loved to use olive oil. She used it as a body lotion. She put it all over her food, the importance of that Mediterranean diet. And for lunch every day, she had a glass of really bad port. She said really bad wine, cheap wine, excuse me, not bad. And I think it's important because actually we're showing that some of those types of port and wines that are made are actually full of antioxidants and other things that actually may benefit. So she had something going for her. And she was just awake. And the other thing she did was she ate 2 pounds of chocolate a week, which actually, you know, she didn't gain weight because she was doing so much exercise, which was good, but she was getting a lot of antioxidants from the chocolate. So you got to mix things together. So I'll mention to you briefly this ATN very quickly before I go briefly into our slides, but this is the whole issue of, can we diagnose people with scanners? Can we spend a lot of money scanning and decide that somebody has amyloid tau and neurodegeneration, and especially if they just have amyloid and tau, can we treat them? And there's a lot of people saying, now, wait a minute, even people with amyloid, you know, unusual amyloid in the brain, you know, they die without ever knowing without ever appearing to have cognitive impairment. So all of these things are becoming an issue because if we identified people very early, it would cost $200 billion a year to give them amyloid drugs that we're not even sure work, and shouldn't be given to patients with MCI. And our overall drugs across the world cost $333 billion. So it's a real question of the usefulness of that. So there's a lot of discussion going on. Let me talk to you briefly about our Alzheimer's Center. Go down to the picture of the next slide. So we're one of a set of 32 centers across the country. These are specially funded studies that are considered centers of excellence that have been denoted throughout by the National Institute of Health, National Institutes of Health. And there are over 42,000 participants in these studies. And the important thing is each of them comes in, gets the same measures, the same blood taken, the same imaging studies, so that now, rather than me doing a study like I did quite a while back of 20 people with an amyloid scan, we can now look at 42,000 people with an amyloid scan. Because now we can compare scanners because all the same scanners have been tuned together. This is really an exciting spot in research, and we're really happy to be part of this group. Next slide. So we're desperate to have your help. We do a lot of research, clinical trials, medication trials, memory studies, because we're still trying to find the right medication. We're looking at tuning different types of medications together, but then at the same time, we're looking at memory training studies. We look at lifestyle intervention studies. We're looking a lot about biomarker studies, blood biomarker studies. We have going on, and a central work is towards caregiver trials in our study. We follow patients through what's called our MMAP. We follow patients and we follow healthy controls just on a yearly basis, just to monitor how things are going. Doesn't take the place of the doctor's appointment, but it looks more in depth at medical things. And it also gives us a group of people who right from the start can be the first ones into new studies, research studies. Next study. We're looking at a lot of different, sorry, I'm one more picture on. I keep forgetting to show next slide. But that previous slide was of our UMMAP study, our study where we follow people. Then on the next slide, we list a couple of other studies. The Armada study looking at new ways of actually bringing computers into the community to look for people with mild cognitive changes. The ACE project and couples well-being, sort of looking at tailored programs for African Americans and white participants in sort of tailored programs to their communities where they live. We're also looking at studies that look at brain stimulation. So we know that this cognitive training works, but in some ways it looks like it works even better if we use very low voltage, sort of a 9-volt battery worth of voltage kind of applied to the brain. You can pick these things up on Amazon. Don't do it. You should use the real thing, and we're doing those studies very carefully. But we do more than research. The next slide, and then the next slide. We're looking very carefully at our brain bank, which is our participants have the right to donate their brains so that this critical research can go on to really look at what's happening in Alzheimer's from cell to cell. Next slide. We have different initiatives, the Lewy Body Initiative, to giving care and work in this very significant disorder. Next slide. We also do a lot of work in our wellness initiative, where we try to provide wellness and stress resilience not only to patients but also to their caregivers, to try to develop these things. I have my picture of Laura at the bottom, who leads a lot of this work, so that every time I see her, I feel nice and relaxed. So now I can finish my slides. We have another wellness initiative expansion that's going on, where we're going to look very carefully and work with the Alzheimer's Association around trying to get talks out there and interactions out there for participants with who we've diagnosed or others have diagnosed with MCI and early stage dementia and things that's working on. Next slide. We have a lot of our outgoing talks, like mine and a lot of other talks going on this year by a lot of individuals. Next slide. I'm going to end on this slide, really, rather than sort of finishing up a few odds and ends, by just telling you we need you to volunteer for research. We need you to volunteer for the Alzheimer's Association. You need to help the Alzheimer's Association in its mission. You need to take part in the Alzheimer's State Advocacy Day and also in the Walk to End Alzheimer's. All of these things are critically important. You need to get involved in the things we do at our Alzheimer's Center so we can further spread the word about the importance of research in this area. And I'll stop there, and sorry about that. I probably killed all of our time, right?
Not at all. You're fine.
Okay.
I just want to remind everyone that we do have a few minutes for question and answers. While I'm going to give you some time if you'd like to submit those in the chat box. Again, that if you're trying to find that, if you put your cursor up towards the right-hand top corner of your screen, it should bring down that pull-down menu, and you shall see the box that says chat. You can enter a question into that, and we will ask Dr. Giordani your question.
Yep, and I have to apologize to you all because this is our sort of first time in doing this virtually, and when we go back, Aaron is going to yell at me about too many slides and talking too fast, but we'll work on it. I'll work on it. So sorry about that. Questions?
Aaron, if you could stop sharing your screen, then I think we can get Bruno full screen to answer questions.
Oh, that's scary.
There he is. Yay, perfect. Thank you so much. Again, you can enter questions in the chat box. In the meantime, I just want to thank Bruno so very much, and our sincere appreciation to the Michigan Alzheimer's Disease Center. This is the part where I would normally be standing in front of everyone and saying, can we have a big round of applause? But since we can't do that, let me see if I can come up with something for him.
That's okay. Oh, yeah.
There we go.
Thank you. Thank you.
Okay.
I really enjoy doing these talks. So this is our first one to try out. And also, by the way, the little guy downstairs is now running around happily singing and dancing. So I don't know what the last screen fit was about, but.
No worries. Just to remind everyone, from our presentation today, we all learned that there's lots of great things happening in Alzheimer's research. The Alzheimer's Association will not stop until we achieve our vision of a world without Alzheimer's disease, but we can't meet that vision without you. Like Bruno said, we need your help. Please contact me at crobinson@alz.org. It is in the chat box. To join our cause by getting involved. And remember, if you do so today, you will get a free Walk to End Alzheimer's tumbler. And yes, you get a free gift today if you joined the walk. Okay, it looks like we do have a couple questions, so I'm going to read those.
Okay.
The first question is from Linda. Any efficacy in the 40 megahertz light therapy on amyloid plaque or dementia?
You know, that's a really interesting question because that was sort of it was one of the studies that came out along with 40 megahertz sound. And you can even buy for your computer, you can get yourself a sort of sound deadener to sleep or other things that's 40 megahertz sound that's also supposed to penetrate the brain. These studies actually looked quite interesting in animals in many ways, but honestly have not panned out yet. However, light therapy, that type of light therapy, though, appears to really be helpful for Alzheimer's patients in terms of regularizing their days and actually may help sleep. So maybe that was having an effect because of better sleep and things. We don't know yet. There's a lot more research going on, and there's a lot of interest in light therapy, but sound as well has become an interesting feature. The difficulty is that little things we do to mice don't seem to work when they get converted to us. Those little tiny brains in a mouse don't seem to reconvert to our big brain, but we're trying to better understand that.
Great, thank you. Well, next question, what are the most recommended drugs currently for treating symptoms of dementia? My dad is on memantine.
Yep. There's memantine, there's Aricept, there's there's a sort of a triad set of drugs. But again, now memantine is a little bit different because it affects a little bit different system than the cholinergic system. But these are all basically drugs that, even though memantine may have some other effects, but they're basically drugs that infuse the brain with extra neurochemicals, so the brain can send messages easily. So it's sort of like the idea that if you're on 23 with construction, you open another lane suddenly. It helps for a while, but it doesn't stop the congestion in the end. It doesn't stop the brain. These are called symptomatic drugs. As yet, we have no disease-altering drug. That's what we're trying to work on. And frankly, other than those expected drugs like Aricept and memantine, that's it. We don't have any other drugs that are really approved. There's all sorts of nutraceuticals people are selling on the internet and other things like that, but those just have been shown to have, those don't have an effect, or they've never been tried. If you listen on TV lately, I notice there's an awful lot of things appearing on TV to help your memory and things like that. But if you read the bottom, it says that these things have not been shown to improve memory through FDA trials. So it's still, these things, we're still working on it, but we don't have a way of stopping the disease or turning it back. Right now, we can just sort of help the cells interact. So memantine is a first run drug along with Aricept. Usually people will go to Aricept first.
Okay, thank you. Next question is from Bertha regarding vision and hearing loss. Do we know if there's a difference in risk if loss is acquired from loud noises or exposure, or if that hearing loss is genetic? And she also says, thank you.
Yep. Oh, thank you. So, oh, you're welcome, I should have said, sorry. So look, this is another important piece that nobody understands. So 2 years ago, the just shows you how these things work. 2 years ago, the Alzheimer's disease organization in Europe, that actually encompasses all of the rest of the world except the United States, where the Alzheimer's Association is. The Alzheimer's International sort of takes the rest of the world into it, especially Europe, did a gigantic review of everything we know about all these risk factors in life and how much they put what. And 2 years ago at the AAIC meeting, I remember there was like shock when these famous people all got up together in a panel and said uncorrected hearing is the biggest risk factor. Now it's very tiny because all these risk factors are only small, but it was more of a risk than ApoE, which is sort of a risk gene, which really was to everybody's surprise, and nobody quite knows yet. Now the sort of interests in vision that are coming along and things, and saying, wait a minute, it's not just hearing, it may be vision. The tie-in is that all of these things relate to how we interact in the world. So it may be the effect of our interaction with the world, and we know if people shrink away from the world or if people become depressed, that also is a risk factor. Or it may be important because it's showing us the earliest signs of what may be going on in the brain. We just don't know. It may simply be that this hearing is just an incredibly early indicator of a problem that's about to start. But it does appear that correcting that hearing has an effect. Right now we're doing two different studies here at the University of Michigan looking at patients with cochlear transplants. So rather than looking at hearing aids, they can actually have surgery and have a cochlear transplant. We're studying both of those individuals over time. What happens to people once they have corrected hearing from cochlear transplant versus hearing? Do we see any changes there? We just don't know these things yet. That was a total surprise. And honestly, part of all this stuff going on too now is because it was very clear at the 2019 AAIC meeting that, and really became clear, ongoing now too with the Diane 2 study not having clear results was, guys, we need to start looking very carefully at other avenues of thought rather than amyloid is the key. So that's why suddenly hearing has become interested. That's why there's so much of an interest in those 4 lines of things, that sort of idea of eat right, take care of your brain, exercise, and take care of your behavior and your cognition. Interact with people, improve your brain. Those 4 things that underlie all of the Alzheimer's Association's coordination of these giant studies going on around the world, that's why there's so much interest in those. Because now all of a sudden we're sort of realizing that maybe we need to do something about it, much more so, because there's no magic bullet pill coming along yet, or no magic sequence of bullets coming along yet. Sorry, I babble on. I'll be quiet.
That's fine. We do have a couple more questions if we have time.
In the back of the room, waving wildly her arms, saying, "Cut it off, Bruno." But
we're okay. We're okay. In the case of LATE, LATE, are there tests to identify that protein?
That is an interesting thing. There is a new blood test that may indicate this alpha-synuclein, that may indicate this protein. But as of now, there's the only way to give a diagnosis of that, a true diagnosis of that, is with an autopsy. But honestly, my mother really was carrying on even her. Post-op. Afterwards, we realized that in her mid-80s, late 80s, she was beginning to have problems, because then when we went back through all of her paperwork, because she did her own stocks, she did all of her own legal work. She had been a big attorney in Washington, D.C. for the government. But afterwards, we began to see this deterioration. But the things we noticed about her as she developed this in her late 80s and into her 90s was there were more behavior change, and that the meds didn't even seem to be helping as well. So if we had done an autopsy, which we didn't do given what was going on and everything, it would have probably shown late, not Alzheimer's disease. She wasn't part of our autopsy study, honestly, because as adorable as my mother was as an attorney, every time we gave her a consent form, she handed it back with a ton of corrections, and she did a lot of questioning, and it was easier if she was happy at home. Sorry.
That's amazing.
My mother was my mother, I love her dearly, but boy, you couldn't get her in a research study because she just was a little overthinking everything.
Right. Well, I think that is our time. We do have a few more questions, but what we'll do is we will go ahead and submit those to you, Bruno, and then as long as we have an email address for those folks, we can email them back. I think Cassidy's trying to say something.
I wanted to also reiterate, I don't know if you saw, but Cami did pop in the link to visit the registration for the Alzheimer's, Walk to End Alzheimer's, and her email again if you have any questions or want to email her directly about questions about Walk. And then I'm going to go ahead and pop in a link real quick if anybody would like to donate to the Alzheimer's Association to help us continue to fund research and keep our education and support free to our communities.
You know what I should tell you at this point? This is the part where Tammy or Aaron or somebody says, and those of you in the room, Dr. Giordani will stay around to answer your questions because he's talked too much. But
I have never said because you've talked too much. I know I've never said that.
You've thought it. But you've thought it.
We may have thought it. We never said it. So we will actually I'm going to go ahead and leave the screen open for a little while. If you have more questions, Bruno, if you want to stay, that's fine. If not, we can.
Well, I can if people have more questions. I don't know if that'll work somehow. I don't mind. But
Well, we'll give it a few more minutes. There are a couple more questions I can read if you want to answer those. Let's see, what was the next one? Or maybe you can even look in the chat. Let's see, what are some of the most recommended strategies for improving cognition? For example, how does reading a novel compare to doing a puzzle?
Oh, good point. Actually, they both seem to be effective because if you're reading a novel, then you are thinking, you're using reading, you're doing all those little pieces like you're supposed to do in terms of reading and things like that. But you know, playing a puzzle, you're thinking and working and interacting. But you know, a lot of times we've found that really it's that harder interaction that works. So although those things are probably important, in studies we do where we do cognitive training, where we use computers to do sort of game-like training and things, our comparison group is often doing a puzzle. So rather than sitting around doing nothing, we have them doing some little computer puzzles and things. But it seems to be that higher level demand. So you know, things that take a little bit of brain strain that really seem to be what's most effective. But there are all those other things too besides that, like exercise and watching your diet and health. These are all these 4 key components in this. They all need to go together well. But I mean, it's part of the point. It's like little mice. We found that a little mouse in his own little happy cell, you know, his own little happy box where he's happy, he moves around. If you drop a wheel in there, then he's running around happy and his risk begins to reduce even more. If you drop a whole bunch of other mice with little wheels and they're all running around, their risk seems to drop. And then if you put all that stuff in a maze, so they're wandering around in a maze and they're doing those exercises, sort of like people do in the park, their risk drops even further. So increasing the complexity of demand and increasing the type of demand all makes a difference. My mother, being my mother, used to say a good argument at dinner really helped your brain. I mean, you know, I kind of like just eating, but it
Oh, goodness. I wish I could have met your mom. Okay.
Many in the Alzheimer's Association met my mom.
Right. I did not, unfortunately. Yeah. I think that this is the last question we have in the chat box. It will be interesting to see if there is a difference in the type of social contact, such as interactions with others who are very connected to others via social media versus face-to-face human contact.
Excellent. Yes, that's really going to be something. And I'll tell you what it really, in my other part of my life, I run a large training institute at the university for psychiatrists and psychologists and social workers and speech therapists and things. And now, of course, everything's done virtually. So what does it mean to have 2 people virtually talking to each other? And now there's a lot of interest in getting people together. So there's a lot of research going on in chat rooms and things. But how do those things differ from that face-to-face human interaction? I can tell you that a lot of the psychologists, social workers working for me are actually getting pretty tired of staring at that computer screen, and they want to see the person face to face. But I mean, we just don't know yet. I'll tell you one thing that not that I'm encouraging it, but parties are something very interesting, because when you go into a party, you really have to use, so if you're in a group situation that's not so much a chat room, but if you're in a group situation where you can listen to multiple things at the same time and try and decide which direction do I want to go, and I'm not going to listen to these things, I'm going to listen to those things. Those are, again, sort of higher level mental processes. So it's going to be really interesting to see what happens. There are, by the way, just to finish, some interesting things that were done in England a few years back, really interesting studies that went into senior residences where people were basically kind of had physical problems and basically weren't getting around, and they brought in sort of Facebook. I mean, they brought in people on the computer and everybody had a screen, and that significantly improved sleep and thinking and other factors. So that was really important. So we know that helps. I mean, even getting on your screen to talk to your grandchildren. A study was done at University of Oregon where they have a whole study center, a big, huge apartment building. Wish we had something like that here. That's all the rooms are outfitted, and there's all sorts of study stuff going on, looking at ways to improve cognition or to follow cognition and things. And one of the things they found that really improved the mood of older individuals was this was actually done before the time of an easy tablet where we all have tablets. They had a tablet on a robot. And this robot just sort of rolled around and knocked on somebody's door, and then you spent 20 minutes with your family on the screen. Oh. So that was before the time of iPads. That showed a significant improvement in how people felt in their mood, and even their thinking improved by having that constant contact. So bits and pieces are better than other bits and pieces. So staying in contact, even if it's over the internet, is critically important.
Well, I can absolutely say that staying in contact with you and having the opportunity for you to do that, even over the internet, is better than nothing. It's definitely not as good as being with you in person, because we absolutely enjoy that. But thank you so much for doing this today. We really appreciate it.
I always like doing this. So.
Thank you to Erin from MADC for your assistance. Thank you, Cassidy, for your assistance with moderating. And again, we do have another presentation coming up on Thursday at 5:30. So if you'd like any additional information on that, if you'd like to join us again, or if you know someone who didn't get a chance to join, please let them know. And we will see you then, Bruno.
Is that Thursday is me again?
Yes.
Okay.
It's you again.
We'll slow down. We'll figure. Okay.
Awesome.
Practice makes perfect.
Thank you, everyone. We appreciate you joining.
Bye, everybody. Bye.
Thank you. Bye-bye.